nice to see the kind of articles which he has already contributed, in spite of being his busy schedule, is in evidence-based policies, urban infrastructure development, financial planning, monitoring and leading, and corporate handling, strategic planning, analytic forecasting. So I think, sir, you are the best one, and it's a privilege to have you. And we are so happy to have you. A round of applause for our expert today. And despite having a busy schedule, we have taken time to be the speaker in this group. Sir, today we have two batches with us. This is an executive program on public health policy, leadership, and management. It's a 6 months program where there are 2 sessions, and we have a very structured modules which are delivered to these participants to learning management system. In this mic, and I'm rotating it to my participants, and they will be introducing in brief their name, their organization, so that the speaker should also get aware who he is talking to.
Good morning. Thank you, sir. Good morning, Dr. Rajasthan. I'm scientist F at AIIMS Jodhpur, and I work on sickle cell and immunoglobulopathies. Good morning, I'm Dr. Rajan Goa, working as State Immunization Officer at CMO for Family Medicine. I'm from AIIMS. I am mostly fundings, so we fund malaria research.
Very good morning, sir. I am Dr. Varuna Vyas, and I work as Associate Professor in the Department of Pediatrics here at AIIMS.
Good morning, Dr. Sir. I'm Dr. Dushyant Gehlot in Jodhpur. Before that, I have worked with various ministries in New Delhi.
Good morning, sir. I'm Dr. Ashutosh Sharma. I'm working as Associate Professor in Department of Community Medicine in GMC, Medical College.
Good morning, sir. I'm Dr. Arya Raghavan. I am a scientist B at ICMR Medtech Research Center, Puducherry.
I think on online we need not to stand up. We'll be on chair and then say.
Yes. Good morning, sir. I am Captain Rennie. I am working medical officer and administrative officer in Armed Army Medical Corps.
That's good.
Good morning, sir. My name is Sheikh Mohammed. I am scientist C at AIIMS Delhi.
Good morning, sir. I am Dr. Dilpreet Pandher. I am professor in Gynae Department in Govt Medical College and Hospital, Chennai. Good morning, sir. I am Dr. Shalini Verma from United Nations Development Program. I am the research monitoring and evaluation lead for the health portfolio. Currently working on the COVID program.
Hello, sir. Myself Fida, working as clinical dietitian in ICRA International Hospital and Research Center, Calicut, Kerala.
I am Dr. Nisha from ICMR headquarters, working as scientist in the NCV division.
Good morning, sir. I'm Dr. Janesh Kumar Gautam. I'm working as scientist B in ICMR Institute, which is situated in Jodhpur, National Institute for Implementation Research, or NCDs.
Good morning. I am Dr. Ekta Gupta. I am a scientist at NICPR, Cancer Prevention Research Institute.
Good morning, sir. I am Dr. Prashant Kumar Singh. I work as a scientist with the ICMR, National Institute of Cancer Prevention and Research, and I am also the nodal officer of the WHO FCTC knowledge around smokeless tobacco. Thank you.
Good morning, sir. I am Dr. Nitika. I am working as scientist at ICMR headquarters.
Good morning to sir and dear friends. Myself Dr. Ashok Kumar. I am working as Associate Professor and Chief Nursing Officer at AIIMS Jodhpur. Thank you.
Good morning, sir. I am Dr. Suresh Sharma, working as Professor and Principal at College of Nursing in Jodhpur.
Morning, sir. Myself Dr. Sheshkaran Singh, Administrative Head and Consultant Dental Surgeon, Trustee Hospital, Bardhaman.
Very good morning, sir. I'm Dr. Stuti Bhargav. I'm a scientist and program officer in the Division of Non-Communicable Diseases, ICMR headquarters in New Delhi. And
Morning, sir. This is Dr. Manoj Kumar Gupta. I'm an additional professor in Department of Community Medicine and Family Medicine at AIIMS.
Very good morning, sir. Myself, Dr. Anurag Sharma. I'm working at the Rajasthan State Health Assurance Agency Office, Jaipur, as a post of the medical officer. Thank you.
Good morning, sir. I am Dr. Sandeep Mukhopadhyay, Scientist E, Deputy Director of AIIMS, National Institute of Cholera and Endemic Diseases, Kolkata.
Good morning, sir. I am Dr. Shashi Gandhi, Professor Microbiology, MGM Medical College, Indore, Madhya Pradesh.
Good morning, sir. This is Dr. Vandana Sharma, Assistant Director, Hospital Administration, Directorate of Medical Education.
So, morning, guys. I'll just interrupt you. It would have been much better. I would have been there along with you, and we would have interacted in person. So, I could not spare actually time and come all the way down to the Jodhpur. Although Jodhpur is my hometown, it would have been for me also a like day off. Am I audible? Yes. Am I audible? Thank you. So, morning to all of you, and I welcome. I believe the participants are from across the states, and the State Department of Health has also telecasting live it to the many other peoples. And we are expecting audience of around how many audience we are expecting now connected? More than 50,000 audience are connected listening this class. So without any additional cost to the AIIMS, we are publishing your publicity. And then some sort of publicity also.
Thank you so much, sir. I think that is where I think academia always requests the administration and the public health, the people who actually are implementers. So it's a kind of a handholding, and thank you for accepting this.
Dr. Bhargava, thank you for my generous introduction. I'll just introduce myself. I did my MBBS from Jodhpur Medical College only, and I belong to Jodhpur, a village nearby Jodhpur city. My schooling was mostly in village. Then I got into service, IAS, and then I did masters in economics. And after that, in 2017-18, I did masters in public health from Johns Hopkins University. And I'm like an accidental academics. So in between my job, I do write articles, and most of the articles are serious articles, research-based, evidence-based, and I do use even the Stata software similar to the S or R software, or what we call is another third one. So I do modeling and all sort of activities. So I have a lot of interest in the public health, and in fact I'm pursuing public health for the last 10 years. Before this, year 15, 16, before going to the Hopkins, I was a special secretary medical education also. So the society model, what we call it, Rajasthan Medical Education Society, was established. The rules, regulations, and all detailing was done by me. At that time, I was special. And in fact, out of the department also, I was pushing art from finance department. Last 3 years, I was in finance department, respective finance and budget. So I had a lot of access for pushing agenda into the public health. And this is the time, so I was asked to come here. And since last 3-4 months, I am here. So it's my, actually, I feel privileged and thankful to the state government giving me an opportunity so that I can use my learning. I worked as a medical officer also in Bardmer and Jaisalmer. Maybe not more than 1 year. Then meanwhile, I got into the job. Sure. Yesterday, we have circulated full PPT of maybe like 38 and 40 slides. So what I call is the PPT and Excel sheets are most dangerous tools. So instead of making 30, 40, 50 odd PPTs, I just circulated, and I hope the audience has already gone through it. And since all of you are like in the middle of the career or in the second half of the career, and you all are senior colleagues, and many of them are the professors and in serious students. So I have nothing actually to teach you, but we will try to explore what ails the health sector in India, how the health sector have been performing in India. So what we will do is the whole discussion will run till 11 o'clock. Maybe you have given me 10:45 time, but I'll spill over another 15 minutes. After that, I have another meeting with the minister and the field officers also. So we will wind up by the 11 o'clock. So I'll request now you put the presentation. There are only 8 or 10 slides, and then we will have a discussion. And same time, the what we are discussing and what we are speaking around more than 50,000 plus public health guys. Basically, these are the doctors, the field doctors, the staff, the allied health services staffs, and CHOs, and everybody in the state. And many of them are audience or international audience are also connected. So most of the time, I believe the questions should be in the English, maybe sometimes in Hindi also. So it will be for benefit for all. So now I request slide. Who is going to put the slide? So आप slide डाल दें for the PPT and we'll come to that. Dr. Bhardwaj, you want to add anything, or shall I go ahead?
So would like to know whether the slides would be displayed from your side, sir, or should be displayed from our side. So whatever you suggest.
Slides to आपने you hosted, so you please show the slide. We will discuss the slide for 15 minutes and then we'll come to the discussion.
Okay, sir. So let me ask my team to do it. So give me another 2 minutes. Sir, as my team is going to start the presentation. So one question which is always coming in our mind, because we have been discussing this policy making program and leadership and management for 6 months together, is as an administrator, what do you think is the most important point is lacking when there is a policy is being enacted, whether it is inaction during the time when the policy is being made or implementation? So these are two very basic questions, because easiest answer which we are getting everywhere is that implementation में problem होगी, बनती है बहुत अच्छी है. So is it a fact or policy making में भी कहीं ना कहीं issues है? So like
I think you have asked very relevant question and very pertinent question. The problem is like not only the implementation. There is a concept called the design thinking. So how you design the policy, how you design a building, how you design your life. So if I want everybody to use at least 20 steps per day, so I should build an office at the first floor. I should not put lift. So everybody has to go 10 steps or 20 steps or 40 steps every day. This is like design thinking. Similarly, when we are making a policy, whether it's in for health sector, for the social sector, for other sectors, there has to be policy has to be based on the evidence. What we call is the evidence-based policy making. Until unless we do not take the cues from the existing implementation of program and the how policies are doing, and most of the time, unfortunately, we decide things on the basis of emotions. And the one more concept is like immediacy magnetizes us. Urgency, anything urgency, quickly done. Say like COVID has come, now you do this. I was a part of that back room in Rajasthan. So many of the strategies, like say Rajasthan was the first to do the lockdown in the whole country, and it was then followed by the country. So we just moved by the immediacy of the action. Government wants immediate action. Government wants popular program. We have to do that. But along with, once we are crafting a policy, I'll use the word crafting, or designing a policy, we should take a lot of evidence into consideration. One, and then frame the policy according to the local needs. Probably that will solve the half of the problem of the implementation. A wrong policy formation or a bad policy, I call it a bad policy. You must have read about the Bardak memo and how the policy arrived at, what are the options and how you review that, and then you come to the conclusion after a certain trade-off. So, is a faulty policy is responsible for 50% failure of the public health programs. Not only public health programs, other public programs. So, the policy designing and policy crafting is very must, and probably that's why I impressed upon the government last year to open at least 7 public health schools in the state. We just have one operational in the Jaipur, and also in Jodhpur is coming up next session. So that will help us to understand the whole gamut of the public health. So to today largely say like we are spending almost $2 billion on the health care, $2.5 billion including tertiary care hospitals in the state of Rajasthan, which is more than 7% of the total budgetary allocation and highest among the whole country. So, and we need to be very, very cautious about the policy formation. Yeah. You are not audible, you are speaker off. Okay.
Yes.
Yeah.
Thank you. Yeah, thank you so much, sir. I think that's the most important point which you brought out, that evidence based. And you'll be happy to know, sir, in one of the module we have talked about this evidence based policy making, or we have started calling it the health policy system research, the HPSR. And sir, we do have with us two of the experts who are also in the room. One is Professor Sanjeev Kumar. I think you must be knowing him. Professor Sanjeev Kumar is our earlier executive director in NHSRC Delhi, and we also have Professor Sonu Goyal, who is from PGI, Chandigarh School of Public Health. And these both are also part of this and we actually devised the entire program. So, sir, now we are going to start your presentation, and I hope my team will be able to put it in place so that sir can start. So, can you see the slides?
Yeah, it's visible.
So, you can say next, and then we keep it next. So, my team will do the next slide.
So I'll be just focusing on few initiatives which have been appreciated across the country, and those are going to work as a watersheds in the country. In fact, what my forecast was about, my understanding is we are at the cusp of the tipping point. There will be huge transformation in the health sector in just a couple of years. We are just a step away from being the #1 state in the country. Next, please. So it is like last year in budget, the state government has declared will have a universal health coverage, and the government has declared the Rajasthan model of public health. In fact, the word and the phrase was given by me only. I was secretary budget there, and the how the Rajasthan model of public health will come up. So like this, the model has like the 4 or 5 basic structures. One is like health infrastructures. Right from the tertiary care, medical college, nursing college, physiotherapy, PSC, CSC, sub-centers. So we are now 100% saturated in terms of all IPHS norms or any other norm of the Government of India and WHO for India concerned in terms of the infrastructure. And we are one of the state in the country which has medical colleges and nursing colleges at every district headquarters. 10 or 12 nursing colleges will function, medical colleges will be functioning in the next year, but we have sanctioned, and more than 15 are already functioning, and 4 are adding this year. Similarly, the supply of health manpower. So what I understood is the health sector problems, the shortage of the health manpower. Health manpower means the doctors, the paramedics, and all other allied health services. I include all in the health manpower. So that is like basically due to the faulty policies, and I will clearly blame the Medical Council of India, Nursing Council, and the similar other councils for this. They have miserably failed, and they have good share of failing our healthcare system in India. So that's why there are some reforms there. So we need to address this issue from improving the supply side management of the health profession. And I'll just say, Dr. Pankaj, I'm one of the experts. There are only 4 or 5 people who write about the human health and power about India, and I'm a practicing expert in this also. I published an article on Rajasthan, as well as another article on India is underway. So then third is like how we can do health finance. So and sustainable health financing need not only the government resources, the all connected aspects. So the Rajasthan has set an example of Chiranjeevi Swasthya schemes. We will discuss further and how we go about it, and then how the whole spectrum of reducing the out-of-pocket expenditure will be ensured. So that will this is in the next slide. Well, there are two more aspects in last, please. Two more aspects, please. So two more aspects is one is like the procurement of health services, medicines, and the other. This is a very big issue. How efficient we can have. Here we have Rajasthan Medical Corporation. Similar structure we have in Tamil Nadu also. And in fact, we borrowed it from Tamil Nadu. And then last but not least, most important is the quality aspect of the services. The Government of India also implemented the NQAS and then other certification systems are also there. So how we can ensure that everything putting together creates a Rajasthan model of healthcare, which we will bringing in form of the Right to Health Act and the Rajasthan model of health. Next, please. So what I was saying is how we have ensured this full coverage of healthcare in Rajasthan. Yesterday I shared the slide. Rajasthan has 88% coverage of families in the state, which is much higher, more than double the national average of 38%. And the next state is almost less than 80%, 10 basis points behind us. So reducing the out-of-pocket expenditure, we followed three-pronged strategy. One is the insurance, what we call it the Mukhyamantri Chiranjeevi Yojana. The second one is the Mukhyamantri Nishulk Dawa Yojana, MNDY, and third is the Mukhyamantri Nishulk Janch Yojana. Now we put all together, we call it Mukhyamantri Nishulk Nirogi Rajasthan Yojana. So Nishulk Nirogi Rajasthan Yojana, we call it this now, we clubbed all together. So, and this level of 88% coverage has not been achieved in a single day. You can see from 2011 continuously, the Rajasthan is pursuing this agenda for the reducing out-of-pocket expenditure as well as setting up an efficient infrastructure, then regular and assured manpower supply at different level, and then of course financing. Next, please. So this is how what I was explaining how the universal health coverage, the ultimate objective of all public health programs, whether it's sponsored by WHO or any nationality or any country, is like universal health coverage. Every citizen and each citizen of the state should have access of minimum quality standard healthcare services, and not only healthcare services, the services which are wellness, preventive and promotive health. So not only the curative health services. So what we did is, like for curative health services, we have government institutions and private care providers. And we put all together. So both of them are covered under the Mukhyamantri Chiranjeevi Bima Yojana. Next slide, please. Next, please. So like there are three components in universal health coverage. One is the Nishulk Dawa Yojana. So in Nishulk Dawa Yojana, like when we started somewhere 2011, the number of medicines was just 711. And there were 250 were surgical and sutures and material. So now this year, May 2022, the item has more than 4 times, 5 times. It's a drastic increase. So almost 2,000 medicines, surgicals. So we have expanded this. And you will be surprised to know around more than 3 lakh people are getting benefit of OPD every day, and IPD is around 25. So the hospital supplies are improved by almost 500%. Next, please. This is like the expenditure in medicine, free medicine scheme. So we started from 100 crore odd in 2002, which is now stood at more than 1100 crore last year. And this year I am expecting some more than 22 to 2300 crores this expenditure. So it will again double by this end of this financial year. And this covers the almost all 4,000 plus health institutions, including sub-centers. We have around 2,200 PSCs and 700 plus CSCs. Yeah, a lot of numbers are adding this year also. And 14,000 plus sub-centers. We are adding 1,000 sub-centers this year. Next, please. So, Chiranjeevi scheme, the Mukhyamantri Chiranjeevi Yojana, like we have around 1,700 packages, 16,033 packages, and 1.34 crore families are connected. I'll let you know, this is the largest program, insurance program in India. No other insurer, whether private or public, is anywhere close to this. This is the size. And till now, in last 1.5 years or in another 15 months, the beneficiaries were more than 18 years. And we have already made payments of 1,200 crores. And the government participation in numbers of people is almost 50%. And the covered families are given bifurcation, there are the pie chart. So most of them are NFSA and SEC. Now here is a difference with the Government of India schemes, the Ayushman Bharat scheme. So they provide cover only for NFSA and SEC, which is around 59 lakh families in the state. And another difference is like the premium of insurer family is around 1,800 rupees per family. In case of Government of India gives just 60% amount of 1,050 rupees. Limit of the 1,050 rupees. So effectively, the contribution of Government of India and Chiranjeevi is, while I consider this scheme, it is less than 18%. If I put all together, out of LNDY, Nishchay Yojana, Dawai Yojana, the contribution comes less than 8% or 9%. So the handholding is very, very minimal from the government. Next, please. This slide has come up.
Sir, there is a request because we have an updated presentation of yours we received a bit late. So if you're out, can we show that? Because that will take another 3-4 seconds to change. So yeah, so there is an updated presentation. Actually, there were 2 presentations. So now we are presenting the updated one.
Yeah. That's what I was expecting. Only 8 slide presentation. I needed 8-10.
Yes.
I could see they were just something. Yeah. This one was earlier one.
Yeah. This is big now. So I think yes, sir. So this is that presentation, sir.
No.
Yeah. So please tell us where to stop. So can you take it from the first? Yeah. So that's happening.
Yeah, you can start from the first. I'll give it fast.
Yeah.
You can go to the next one. Yeah.
This slide, sir. Should we stay here?
You can go on first slide.
To the first slide.
Yeah. I'll just.
Yeah.
So this is what. Yeah. Next, please. This is what I said. The how the scheme has grown over the 1 decade. Next, please. So we already discussed about the free medicine schemes and number has grown up. Next, please. So this is the amount I am saying this year this will cost the 2,200 crore on medicine alone, which is the and last 3 years on medicine we are number 1 in the whole country in free medicine scheme, and an evaluation done by Government of India. Next, please. So Nishulk Janch Yojana, yes, we have done tremendous job in last 3 years. Now, other than medical colleges, here is the data of like district hospitals. They are covered by the centralized supply, and we are further expanding this. And in medical colleges, more than 1,000 tests made free from this 1st May. And this is unprecedented in the whole country. It's a huge step. So you can understand in this term, if somebody doesn't have insurance, say like 88% families have, those who do not have, even they will get almost everything free. The medicine free and then all diagnostic free. But that will be from government hospital. If somebody had insurance, he can get benefit from 800 odd private hospital across the state. A good quality treatment from all hospitals. Next, please. The next slide. So this is what I was just discussing the Chiranjeevi. See the coverage which we have raised to the 10 lakh. In Government of India, which is only 5 lakh. We have included a road accident insurance coverage of 5 lakh for each member of beneficiary. And another scheme we have introduced for accident, which we are making operational, rather announcing. We have started rolled out on the trial basis for road accident. Anyone from any state, from any country, if somebody has road accident, he will get free treatments for 72 hours. No charges. Even he doesn't have any idea, no insurance, no police formality, which is very progressive steps. And in last 15 days, we benefited 600 people, and the amount is around 50 lakh. Actually, formally we are rolling out next week. It was just trial to fix our software, and because everything is done online, no offline. We have Chiranjeevi and Aljo all on e-platform. Next, please. So this is what I was just asked my guys to show the health expenditure, how it has increased from 15 to 2023. There's a huge jump. And I have not included here the tertiary care. I have just included the medical health, primary and secondary health care expenditure, which is a very, very good symptom for the public health care. In tertiary health care also, we have done a lot of things and have deliberately avoided that. And in Government of India assessment, last month they said the Rajasthan is the only major state which has crossed the 7% of state budgetary allocation, which is a huge stride, a huge force. Next, please. Next slide, please. So now point comes how we can assure the basic right, basic human right, or the basic need of a person having access to the rightful health, the rightful nutrition, and there is a legal mechanism to avail these remedies if there is any issue. So creating a just society where the people can have 2-3 things like education and the health and the basic social services. So here, the Rajasthan government has come out with a budgetary announcement to implement the right to health, and it's under process. I think a couple of weeks we'll be going to get through from the legislatures, and then we'll implement it. So how this will be framed. Since you all guys are the public health experts, and later on any suggestion from you also will have a space to be occupied. So what we are focusing on to ensure this right to health, so like creating the range of health infrastructure facility, which I told we have 100% saturated all level of health infrastructures, except the public health school, which will be next 2 years. Then the second is quality training institutional frameworks. Last slide. Now do the next. Go to the back slide. So the पहले वाली slide में जाइए भैया. Previous slide. So quality training institutions, yes, we are focused right from not only the medical college, nursing college, physiotherapy college, even Ayurveda and naturopathy colleges, apart from the public health, and then different state kind of institutions we see in the Tamil Nadu and Karnataka. So there are a lot of trust institutions, research institutions, autonomous institutions. And how we ensure quality healthcare with equity. Equity is very, very important in healthcare, and that needs to be addressed. And we also lie in the mechanism Chiranjeevi used up to a large extent. And how the sustainable health financing framework we can establish, which we are in all 3 aspects and 4 aspects. The Rajasthan has already done most of the job, and we are far ahead in many ways. And then comes like how we can have cost-effective healthcare. If we go for the US model of the costly healthcare, or like maybe European are still better, but they are very costly when it comes to the 8 to 10 or 11% of the GDP expenditure. Probably India will not be in position to go in that range. Currently, we are somewhere between 0.5 or 1%, or maybe 0.5, 0.6% of GDP. If we reach like 2 or 3%, and then we get the same results, that's where we comes in the role of the cost-effective healthcare and the pioneer experts in the cost-effective healthcare in India. And what we are aspiring in this Right to Health Act is the new dimensions to the healthcare industry. The health accounting system, we have already started with the help of WHO. The future course of health industry, where the health should go, and can we export the health professional from the states? And we will actually be going to do in the next couple of years. We are on that stage. Next, please. So now comes what are the issues in the health, public health. So the public health is largely, I will say, trusting healthcare minus everything is public health. Also, this trusting healthcare is public health, but that's only 10%. 90% rest is very important, and only the trusting healthcare. So the infrastructure. The first issue. Now we have set the infrastructure. The problem will come running, maintenance. We have to innovate in pre-term projects, how to do the services, and then many other mechanisms how we can do it. All these topics need independent lot of research and work on those things, where you guys can actually direct the governments how they can be done and what we should think of. Even currently, when we are creating infrastructure, we should keep in mind this should be of optimum size, not the bigger size. The building sizes, the recurring costs, should keep all these in mind when we design the policies. Like I say like IPHS norms, I'll show you the books I have with me. I keep all the Bibles issued by the Government of India in my, these are here with me. So they created I'm not making mockery of them. So they created a CSC per bed. The area constructed is more than 3,300 square feet. How can you have a huge building per bed 33? While the norms for US and the European countries per bed, the area is around 1,400 to 1,600 or maybe somewhere 1,200. For us, then firstly care is 600. And for Ayushman Bharat, we say 80 square feet per bed. At the same time, in Chiranjeevi, we are still better. 220 square feet at least per bed. So, where is the 280 square feet bed in Ayushman Bharat or a CSC suggested by the Government of India? 3,400 square feet per bed construction. So, my question is, how you will implement this project? Because CSC cost will go 6-7 crore rupees. So, do we have some mind to apply and reduce the appropriate size? So, here comes the role of policy, you guys and me. So designing the policy as per the need, optimum size, optimizing the size. This is the one example. Same with the district hospital, same with the PSCs, I read and all. And we have come up with a new concept of 10-bed CSC. We are going to implement CSC of 10 bed with reduced size and expand agent value. So this is like one example by designing. How you reduce the cost, one-time cost, reduce the land requirement, and reduce the recurring cost of electricity, maintenance, and future cost. These guys are not looking into at all future cost. And they will, once the NHM will go, they will wind up, and the state will be left for all themselves. So these are the issues which you think, and you guys should carry on. And the next comes the when. So vacancies is one thing. So I said there are hardly few health manpower supply expert, and fortunately I am also one of them. There are only few, 4, 5 or 6 who actually do the proper modeling and then see and how they do it. DT also have few person and few in Chandigarh. There are very few people. So the reason is then one is the Government of India last month issued a guideline for specialist cadre and the management cadre. I think, and I actually think the Government Secretary to Government of India, this is a good step. And we are now going to implement. We have already framed the act and it is already with the government for the final approval. So we do not have a specialist cadre separate. We do not have management cadre separate. we expect a doctor to be a logistic expert. We expect doctor to do everything, and at the same time we do not have sufficient doctors. So what happens? Say, like, I give an example. I have 2 nuclear specialists in the state, one in Jaipur, one in Bikaner. So my department or my ministers, they have transferred him on a PSC. That poor chap comes to me, "Saab, main kya karu?" So this is the problem with all kind of specialists. So this problem is not their fault. It is fault us, the secretaries, the doctors, those who are advising the sitting in the Directorate of Medical Health or Public Health, is their fault. They never did it. If we create post for nuclear medicine at the medical college only, he will go only there. Or if he was an earlier medical officer, now he become an expert, we should give a way to change the track, career track, and land there finally. If we cannot take advantage of expert, maybe oncologist, maybe nutritionist, maybe embryologist, whatever. Now, what I am giving example, I had seen in medical education as well as here. So rightfully locating these guys is a big issue. Then comes the utilization of services. So how much efficiently we are using bed capacity, we'll discuss in the one more slide. And then comes, now we never thought about the efficiency improvement of PSCs, CSCs. So कैसे हम उसका task shifting जिसको हम कहते हैं, how we can redistribute the task and assign tasks at the different levels, so that if a task can be done by lower level, should not go to the higher up level. That will spare a lot of manpower for us to be used at appropriate level. And of course, quality, now Government of India also picking up, and we are also doing. And in the last not but least, customer experience. We have very bad customer experience, almost all the government facilities, not only the hospitals, other also. But the responsibility one, and then alternate mechanisms, say like private hospitals, accreditation through insurance schemes, will give a good customer experience for people. Next, please. So these are the issues I flagged for you guys to ponder upon and take it a little bit more deeper, so that when it comes to the policy formulation and suggestions, you will actually understand the problem. So now I had just asked my guys to understand the CSC, how CSCs in Rajasthan are utilized. So they come up with, like, the size of CSC bed per CSC bed is, it was 38 in 2018, now it is 33 bed per CSC average. Some CSCs are 50 bed, 60 bed, even 100 bed also. So that's why size is higher. But now reduced number is, we have opened around 70 CSCs in last 1 year. So the percentage utilization comes around 20, 22 or 23%. It's still not very bad, but mostly due to the one-night admission for the Chiranjeevi to become eligible under the Chiranjeevi scheme. So how, if we can, my experience is the actual utilization of these beds is around some 8 to 10%. So now I frame this like, I have 700 CSCs and the average is 33 bed. So that simply means I have a 21,000 bedded hospital, which is used, its OPD services are, IPD services are used at the rate of just 10, 12% or 15% of capacity. How inefficient we are. How inefficient we have designed the CSC. And that's why we have come up with a model of 10 bed CSCs, which we are going to implement here. And why this is the misplacement of the experts. We do not have the matching medical doctors, like anesthetists, gynecology surgeons, not all together. One of them is missing, so OT will not function. And probably one more, like we have, the WHO has designed the PSC way back in 78 in Almaty Declaration. So their thought process was correct maybe at that time, but now time has come to rethink the PSCs and CSCs. Now we are coming with a new PSC with only 4 bed, not with a 6 bed. We do not need actually 6. In fact, I was in opinion that it could be 3 only. 1. And why not you go for task shifting? Why not you go for the telemedicine and mix up all those and then roll out the services down the line? So next, please. Next slide. So this is like utilization. I conducted a study 2 years ago when I was not in medical. So utilization was very low. Indoor services basically. These guys have come up with more higher side. That due to only Chiranjeevi. So next please. So this I published an article on Rajasthan. So I shared with you guys also. So the supply of how the demand and supply of the doctors. So we always think about the 1 doctor per 1,000 population. Now my question is, as a policy maker, can we think someday 1.5 doctor per 1,000 population? If Russia has a 4 doctors per 1,000, European Union countries or OECD countries have more than 2.4 or 2.8 doctors per 1,000 population. Will India someday think of having 1.5 doctors per 1,000 population? We should. I actually drawn these lines and looking into my forecasting model, which were based on the average exponential growth rate. And unfortunately, in Rajasthan, the current rate of the supply of doctors will still have a lot of gap. Now we have actually increased the pace. Probably will fill this gap by 2035 of 1 doctor per 1,000, not of 1.5. And the nursing and the nursing staff, which we require at least 2.4 per doctor or per 1,000, 2.4 per 1,000, and the best norm is 4.5 per 1,000. These are the norms recommended by WHO and many studies. Next, please. So, like my suggestion will be to you guys, to in your states, in Government of India, and wherever you guys go. So they try to understand what is the supply. Until unless we do not improve the supply, we will not make available enough number of health professionals. And we should increase the supply for 2 reasons. One, social sector, prominently the health sector is the largest employment generator in all developed countries. And it has contribution of employment sector, almost 18% of jobs comes from these sectors. So have all schools, physiotherapy, maybe like technicians, range of technicians, lab technicians and different technicians, maybe nursing staffs, maybe AIIMS, maybe home caregivers. We may create new categories, just the health assistants or something sort of that. So that will create the job, and which we actually need. Now, one more study I conducted 2 years ago. It is small papers I prepare and keep in my laptop only. Many of them are not published. I was looking some collaborator. Some of you may come up and find my research to take it a little bit higher on. So like I did what is the effective availability of manpower? The Roli Singh ma'am is calling from Government of India, so I'll pick up later. So she is the additional secretary there. So how effective the availability of the doctors? Like if you see like 2009 to 18, per PSC the doctor availability is not much. Yeah, we are assuring almost 1 doctor. Specialist availability in CSC, not even 1. For health worker availability is relatively good in Rajasthan. We have already saturated. So these data are a bit dated of 2018, but in last 3 years, there is a lot of improvement has happened. But still, the CSC segment is lagging behind. So this data is like earlier we talked around 20% of bed utilization, which contrary to each other. So since we are not capturing properly the data of bed utilization, so there might be issues. The final argument is like very low utilization of indoor capacity. Next, please. So this what my research paper published assessed. There is still got a lot of gap, and even current we have less than 0.5 doctors per 1,000 population available. But yes, now it has been improving. Next, please. So what I was discussing, we need to rethink the public health and how we can improve the performance of like primary health care. We need to revisit the whole idea of PSC proposed by the WHO. That has actually suboptimally performing and in many part or in pieces it is actually failing. The strategy had worked for last 50 years. Now it is not working up to that expectation. We need to redesign and rethink, and probably one day we'll do it. So maybe there are mechanisms like, as I told earlier, transscripting, telemedicine, redesigning like PSC, CSC, service delivery, engaging the people, private sectors, technologies, strategies, so maybe different models. That's where my idea is to excite the class, inside the class, and motivate you guys to take up these fields instead of just reading books and just having a degree. That's okay, and that will not add much to the system. Next, please. And of course, I told you the supply side management. I famously say we are taking hospitals to the people. Now time has come to reverse it. Bring people to the hospital. That's where the 104, 108, the transport mechanism of the people. There is no need to open too many institutions. Last 5 years in Rajasthan, we closed 21,000 primary schools. Last slide, please. Before previous slide. So we closed 21,000 schools. So instead of having too many hospitals or facilities, we have good hospitals. We have better experience. This we have already discussed, universal health coverage. All things putting together becomes an universal health coverage. Next, please. So one is like Government of India is most of the time over enthusiastic and act like a big brother in healthcare. So health is a state subject. The Government of India needs to understand the southern state, the Kerala, the Tamil Nadu, the Andhra Pradesh, and now Rajasthan. They have performed much better with little help or some help from the Government of India. We always need help from Government of India, but not much interference. Kerala has done without any help, almost very negligible help from the Government of India. Since a state subject and the socio-cultural value different in the different states, so that's the need of R1. And then one more aspect, we have so many silos in health. So if say like I run almost 37 health programs in the state, same with the central governments. There are so many silos and there are so many committees, say like NHM. So they made Chief Minister as a committee head. And for my wonder, in Rajasthan, since 2005, NRHM started, not even single time any Chief Minister took the meeting. So what is the use of forming such a policy? If a committee, the policy suggests a committee that doesn't sit for 10 years, 15 years or 20 years, why do we formulate this committee? We just need to understand. And what I say is, our administration in healthcare is designed for inefficiency. We need to look into it. So like having different management cadres, having specialist cadres, all these are the data. So probably I think this is the last slide. Next, please. Yes, this was the last. So my job was to just to motivate you guys to take up these fields and come up with the ideas, do more research. We are doing wonderful job in healthcare across the country, and the state is certainly leading. And many other states are also doing good. But the Rajasthan is very fast catching up in the last 10 years. From Bimaro to we will be the leading in a couple of years only. And already in many aspects we already have. So this was talk from my side. Now any questions, any interjections, Dr. Pankaj, or any participant?
Yeah, so thank you so much, sir. I think that was very comprehensive, and I know to present the work of a state in 45 minutes or 50 minutes is always a tough job. But I should really appreciate you being an academician myself. I'm a professor, so I know.
Yeah, I'm serious. Serious academician. Very excellent.
Yeah, so it's difficult to see a person with such a passion. So now, sir, we have few questions. I think let me have one question from my side, and then I'll rotate this to the tables if they have some questions. And we request you to be very brief in your questions so that Secretary can answer them specifically. One question from my side, sir, I would like to know is that because now we have started calling two things, that is the time when we talk about social determinants of health, number one, and number two is the time when we talk about health in all policy. So what Rajasthan government is doing in these two areas? One, the addressing the social determinants of health. As we have said, it's not the time to talk about disease anymore. Let's talk about health. And health is not an isolated. The second one is health in all.
So like the very, very pertinent and directed question. So like health will not be like an isolated subject. You just cannot address health by health programs only. So health, say like health or safe drinking water, clean drinking water, there comes the role of the PhD, there comes the role of the Jal Jeevan Mission. I think the Government of India had correctly strike the port there. Swachhata Mission, the toilets, the hygiene habits, 100% goes with this health. That's where the Government of India has perfectly taken up that call, and the states have also done wonderful job. And then comes like many other sectors, say like the ICDS department, the child care, the school health, the programs related with the nutrition improvement and the supplement improvements among the child and the pregnant and lactating mothers. So those also goes with this. And you always need a comprehensive, and of course the level of education. So these are the social determinants we need to address, and there has to be multi-pronged strategy. The hospitals are the tertiary care, secondary or tertiary care, they are the last need. Before that, what we do is actually will be a great contribution for sustainable health and maybe cost-effective health also.
Okay, thank you so much, sir. Thank you so much. Over to others to have questions to the secretary. Yeah, so one of the participants, Dr. Sharma, is having one question to the secretary.
Sir, very nice presentation. Grateful to hear you. I have a question. When we talk about the health, we say either insured or assured. It's very nice to see we have Nisulk Dawai Yojana, we have the Nisulk Janch Yojana, and we have the Chiranjeevi insured based healthcare scheme. How there will be sustainability if we are having freebies in the health? How the load of taxpayers will be beared? How you explain as being a bureaucrat or a master of this chair? Thank you.
A wonderful question, Doctor. When we were deciding and we were discussing preparing the budget for the state government last year, I was the secretary budget and I was sitting with the CM and I was pursuing this only. We should go for the universal health coverage. And the same question was asked by the Honorable Chief Minister, why and how we will ensure. My question was, when I can distribute the salary and the pension of 70,000 crore annually in Rajasthan to just 10 lakh people of the Rajasthan, who are the government employee. If with additional amount of 2,000 crore, I can give good healthcare facilities for at least 6.5 to the 7 crore families out of 8 crore families, it's not costly. One, and I have not yet done proper study, but my estimate says the treatment rendered by the government facilities or government doctors is much highly costlier than what I get same or similar treatment from private sector hospital to the people. So it's like I spend one way for 70,000 crore without any thinking. One more argument, we give 15,000 crore subsidy to the agriculture sector, and that goes to only 5 lakh big farmers, major chunk. And here additional 2,000 crore, total will be around 3,500 crore. 1,500 crore we are already doing. I am saying Chiranjeevi scheme additional 2,000 crore will ensure 6.5 crore लोगों को quality health care. So it's not costly. It's not really costly. And how many lives I can save, how many hours, productive hours they will contribute, that is a big deal. I hope I have replied very well.
Continuation to this question, sir, I'm clinician, so my worry is being freebies, are we or whatever the program, like kind of misusing, like every patient who visits to hospital setting or healthcare center, they don't need always medication. Sometimes they need only just advice only. Being a free available, you have everything there, and patient's expectation that I will go and I will bring this cough syrup, I will bring antibiotic. So, are you looking some long-term, consequences in the negative term? And second, what we all are observing is the high resistance of the antibiotics. So that is real scenario in our country.
The perfect question, Doctor. Well thought after. So there's a concept of moral hazard. So I asked my team to understand the concept and how moral hazard works in health insurance and the overconsumption of the health. See how the free medicines, free charge, or the Chiranjeevi scheme leads to the overconsumption of the health. You perfectly right, perfectly raised the question. So now we need to work on that also. Since till now we had limited facilities, we had limited doctors, now we are insufficient. The next level comes not the counting, not the quantity, now comes the quality. Now comes to check the moral hazards, now comes to check the misuse. And you have raised very well. And we are designing the strategies, but this is a regular process. We have to work on continuous basis. Thank you.
Yeah, thank you, sir. So, any more questions? So, one question which we have been asking even in us, because we are a central ministry organization, so we ask in ministry also and government of India, when we are opening medical school in each and every district, we can ensure number. But how will we assure quality of doctors? Faculty is not there. They have not been trained. A medical officer who's been there for past 10 years has been asked to join as assistant professors. So to develop these kind of human resource, wouldn't you think it could do more harm than benefits?
This is an interesting argument every expert will raise when they expand their class. So the AIIMS guys objected for 30 years not to open new homes. साहब क्वांटिटी डाइल्यूट हो जाएगी. भैया पूरे कंट्री ने क्या नुकसान किया जिनको एम्स की फैसिलिटी नहीं मिले? Do you think Jodhpur AIIMS is not a good institution? And what the AIIMS Delhi did, if you pick up the data of last 20-30 years, more than 60% AIIMS doctors studied free of cost in the Delhi and all went to the foreign. So why do we need AIIMS? Why do we need such institutions? जो हमारे खर्चे पे पड़ के फॉरेन चले जाते हैं. You understand? You bring it. और जोधपुर के एम्स का लड़का नहीं जाएगा, और जाएंगे तो 10% जाएंगे, not the 50%. So there is no issue. I was medical secretary when we opened the first 6 schools. ये जो आपका पाली, बाड़मेर, Vilwada, Bharatpur, and I was given the task to frame the rules. I formulated the Rajmes Society, and then what we did is we made 50% seats paid and 50% seats free for undergraduates, so that we can cross subsidize the education. And that's why now we are staged to open so many schools. Then they said, "Sir, doctors नहीं मिलेंगे." Now you analyze. मेरा regular government college है, अजमेर का वहाँ vacancies ज़्यादा है, बाड़मेर पाली में नहीं है vacancies. So the problem is not the availability of doctors. Problem was in the recruitment process. RPSC takes 3 years to recruit the doctors. So what I did, I barred the RPSC from recruitment in the new medical college, medical society. Now the any principal of medical college, maybe Pali, maybe Jalore Silo, अभी Jalore Silo में कुछ रहे, they can come with any doctor, go to the medical secretary with an expert HOD वहीं अपने साथ के लाते हैं, SMS बुला लेते हैं, get the sign, and in 3 days you can post the doctors. One. And any institution or anything, what do you expect? एक बच्चा पैदा होते क्या दौड़ने लग जाएगा क्या? तो न्यूनेट होगा, फिर इन्फेंट होगा, फिर टोडलर होगा, फिर एडोलसेंट आएगा, फिर एडल्ट आएगा. It's okay. It's okay to take 3-4 years, 5 years to medical college establish. It's okay. Day one मुझे नहीं चाहिए medical college, but down the line 5 years शुरू में बहुत अच्छा medical college होगा. Everybody will have a good facility. अगर हम एम्स नहीं खोलते 20 और वो सारे एम्स के बाहर ही चले जाते, we would not have witnessed experts like you here in the Jodhpur talking to us. So I think that's the enough reply.
I think very validly and very nicely answered, and I should appreciate you. It was really such a nice way to answer this question. Thank you so much. So we have another expert from PGIME at Chandigarh School of Public Health, Professor Sonu Goyal. So he has one question.
Thank you, Dr. Prithvi. I think it was a wonderful insights about what we have done and what Rajasthan government is doing in healthcare sector. And I'm really pleased to see that a lot of AIIMS have been opened, a lot of supply side, I think a lot of initiatives have been taken. But I think being a doctor, you must have realized that we require, all the doctors require, they all have very beautiful technical skills. But most of them lack in managerial skill or leadership skills. So I think this is a course which is really helpful for people across the country to develop those type of skills. But we need to develop more such programs for states of Rajasthan and many other states where they should inculcate some leadership and management skills. So I think that's a food for thought, how we are actually working on developing their some sort of technical skill and leadership skills in state of Rajasthan.
I perfectly agree with that, sir. What you said is 100% correct. So what I did is I got declared 7 public health schools in the state. One in Jaipur we have already started. Jodhpur it is coming the next year, and all divisional headquarters will have in next 3 years. So, and these public health schools, people like you guys sitting there and teaching these people what needed, what is the evidence policy making, how you design a proper policy, how you evaluate and change the midterm strategy, and what failed and what will succeed. And institutional setup is the only setup which can regularly supply, not the only small trainings. So that's why we have gone for large scale of institutional setup. And that's the only way, one. Second, the changes in the health system. We need systems approach. So then I said for logistics, for management, hospital management, down the line, from CSC to medical college. So we have created management cadre separately. We kept the qualification. Here comes the public health schools or hospital managers and other relevant courses. So that's the only way to go into that. And when we bifurcate these tasks, maybe there may be little resistance, but not much resistance. But once these things will settle, we will be in a position to manage. And we are actually doing. We have declared the management cadre, rules have framed, we have set up the 2 institutions, and 5 more are coming. So probably in couple of years, that's why I said in couple of years, we will be in leading position in the state. So thank you very much.
I have one concern. Sir, I am Deepak Saxena, Senior Digital Director. So just wanted to know, because Rajasthan has got very good budget allocation in health sector, this is around 7% something. And this is much above, I suppose, the national average. The thing is, as we noticed from the slides, there is a gross underutilization of primary healthcare services. So are we going to do something about that? And are the people paying from the pocket? Are they able to utilize the services properly? And there was a certain concern that certain mortality rates, like infant mortality rate, maternal mortality rate, in the slides previously shared, so that was found a little higher than the national average. So, and we relook to the policy. That was my concern.
So I said similar concern with the state government at the top level of leadership. 1.5 years ago, when we were declaring universal health coverage and all that, and the Honorable Chief Minister was listening me carefully. And few months ago, he sent me here to address all those issues. Improve the utilization and similar things. So the idea is like, that's where our roles come. The people from the public health schools, people from the health administration, people feel understanding, going into deeper the issues and how we fix up. Like I said, not the availability of doctors, the problem with the recruitment process. So problem with the RPSC, not with the doctor available. Only availability will be very super specialist. The basic doctors, say gynecologist, medicine, surgeon, anesthesia, they all are available. Maybe cardiologist not available. That's okay. We'll get after 5 years in medical college. You do not need very first day cardiologist or endocrinologist or a similar expert. We can start from there. So it's a continuous process, and probably we'll do it. We are on right track. Thank you.
Yeah, thank you so much, sir. It was a wonderful interaction with you, and I know that it's up to take time from the busy schedule to talk to the academician. It's a total all together because you are at the top of the administration. So thank you so much for joining. And as you said, we are there to have this handholding with the School of Public Health, which are coming in the state of Rajasthan. And I would like to share with you is that the Jaipur SPH came. So we were there to to have our views also, to give feedbacks, to give our inputs and reports. So we would be happy to be the part of this and like to share the responsibility of bringing the quality health care professionals in the state of Rajasthan. So thank you so much, sir. Thank you.
काफी और जो ऑडियंस जुड़े हुए हैं, करीब 50,000 के आसपास ऑडियंस आज जुड़े हुए हैं, तो मैं उन सबको धन्यवाद दूंगा और मैं उनको शुभकामनाएं भी दूंगा कि आप सब ने जो ज़्यादातर हेल्थ वर्कर्स भी हमारे के साथ जुड़े हुए अभी, they have done wonderful job in COVID also, and last 10-15 years is a lot of contribution to public health. Is not only like one way, so we all public health practitioner, right from down the line जो हॉस्पिटल की सफाई करता है वो भी हमारा पार्ट है, और तो और जो कॉमन पब्लिक आती है वो भी हमारा पार्ट है. We have all done wonderful job in the state. I congratulate and I assure them the full support, and we will commit ourselves to keep the state on health spectrum at the new level. Thank you very much for joining and inviting me. Have a good day.